statement. How? So the first case that we have seen the other day, this is a 68-year-old female with past history of primary lung cancer and with EGFR mutation, and she has been treated with EGFR TKI for 6 months. And clinically, she developed progressive disease with pleural effusion. So the clinicians suspect disease recurrence and order cytology examination. So in this cytospin preparation, we can see cluster of atypical cells and with three-dimensional architecture and glandular arrangement. In this area, it shows drying artifact, so chromatin pattern is not very clear. But you can see here, it looks more like an adenocarcinoma. However, in other area, you can appreciate the cell has increased NC ratio. The shape of the nucleus looks like what we call OAT. In the old time, small cell carcinoma has been called as OAT cell carcinoma. 燕麦细胞长得很像燕麦哈。So it has an OAT shape and with molding, cellular molding. Okay, so in this area, this looks more like a small cell carcinoma. So the case we've seen last week is a case with small cell transdifferentiation. In the cell block preparation, I think most of the cell looks like small cell. So you have perfect molding and increased NC ratio. And the chromatin pattern is very homogeneous. It looks like misty and a very, very fine granular pattern. So this is also typical for small cell carcinoma. In some of the area, the cell type is actually, the cell morphology is actually intermediate between non-small cell and small cell, because you see quite a lot of cytoplasm here, but the chromatin pattern is still more compatible with salt and paper pattern. So rarely in the small cell carcinoma, if it's well fixed, it can have plenty of cytoplasm. And the scenario is a little bit also different because these cancers are coming from non-small cell with small cell transdifferentiation. So sometimes the morphology can be a little bit ambiguous, but because of the cellular chromatin pattern, and as you can see, there are a lot of apoptotic body within this cluster. Adenocarcinoma usually don't have that. It's more the feature of small cell carcinoma. So you see mitosis, you see apoptotic body, and you see molding over here, and the chromatin pattern is compatible with small cell. So basically, this is also a cluster of small cell carcinoma. So the clinical has already been aware of this situation because we told them last week this is the same patient. So she has to shift to chemotherapy regimen from the EGFR TKI for the recurrence disease. But because she's an elder female, probably they would need to discuss if they want to do the chemotherapy or just refer to hospice. Next specimen is also a pleural effusion. I think it's also lung cancer. Yeah. So she has been confirmed with lung adenocarcinoma by pleural effusion cytology and cell block last week. So we do a TTF1 on another specimen from this patient, and this is positive for TTF1. So for poorly differentiated adenocarcinoma, the size of the nucleus is very big. So you can see it is a huge nucleus. and still have quite plenty cytoplasm with eccentric nuclear pattern, and they are prominent nucleoli in these nuclear. So this is a poorly differentiated adenocarcinoma. The clinician order repeat examination with cell block. I think it is because they need the specimen to do EGFR, but this specimen is also not good. The last specimen we also show very scant tumor cell, and this one as well, very scant. So this is also not good for EGFR testing. So the next specimen is a urine cytology from renal pelvis. So again, we have very hypercellular specimen because it's a washing specimen. It's supposed to have a lot of cells. And in this specimen, it is very obvious that most of the cells are hyperchromatic. And some of the cells show more degenerative feature. But the other, you can see it's well preserved. So here you see very high NC ratio and hyperchromasia. Right next to it, there's an intermediate urothelial cell. So this is very a big contrast. You can see high-grade UC and benign urothelial cell. And this is definitely a positive cell. It looks very bizarre with multinucleation. And what I want to show is that not always all the high-grade urothelial cells have high NC ratio. For example, for this one, the NC ratio is probably 0.5 or even below. Okay? So sometimes, not always, the high-grade UC cell will have a very high NC ratio. You need to be aware of that. But otherwise, majority of the cells show definitely high NC ratio and hyperchromasia. And here we have a very bizarre cell over here. So this is positive for high-grade urothelial cell. This is from upper tract. So once we make this diagnosis, the clinician will need to discuss the patient for the radical nephrectomy treatment. The next specimen is kind of tricky. And it is one of the most challenging area for body fluid cytology. So the patient is a 53-year-old female. She had a past history of thymus squamous cell carcinoma. So thymic carcinoma with squamous differentiation. And this is the pleura effusion from the same patient. The clinical impression is either lung metastasis or lung abscess. So this is cytospin preparation. And in this preparation, the cytotech highlight a couple cells in cluster. So the differential diagnosis will be, is it carcinoma, metastatic carcinoma, or is it reactive mesothelial cell? So this is one of the most challenging area for body fluid cytology. The first thing is that it is always very informative that we know our enemy first. So in this case, our enemy is thymic carcinoma. It's a squamous cell carcinoma, right? So it's supposedly not to show this adeno feature, right? So this is more compatible with the glandular cells instead of the squamous cell carcinoma. So this is the first clue. But if the patient had adenocarcinoma, it would be very difficult, right? So if we go to the cell block, there are definitely some cell cluster showing these glandular feature, but you have to be aware of that. Mesothelial cell, reactive mesothelial cell, usually don't form a cluster. However, if the patient has been received surgery, or we see some procedure, for example, like pigtail or something like that, sometimes it can have mesothelial cluster like floating in the in the body fluid specimen. So this is another thing that you need to be aware. So definitely, if we are dealing with, for example, pancreas cancer, this could be a pancreas cancer, right? But if we are dealing with squamous cell carcinoma, this won't be a squamous cell carcinoma. If we are dealing with lung adenocarcinoma, and this could be yes or no. Usually the lung adeno will have more prominent nuclear atypia, but this one is show very bland looking. We still need some tests to confirm the origin. So originally the cytosec thinks this is a metastatic adenocarcinoma.
动的排烟测试会有风车动作，请勿惊慌。医科中控报告，该委会测试医科大楼的排烟，如果有风车动作，请勿惊慌。
So for the differential diagnosis between metastatic carcinoma versus mesothelial cell, what we like to perform is clouding 4. So this is a new marker, and it's supposed to be very sensitive and specific for epithelial cells, particularly glandular cells. So the clouding 4 for the cell cluster is negative. I also do a TTF1 is negative. I don't think it is squamous cell carcinoma, so I didn't do P40. And then I do creatinine. So creatinine is the marker for mesothelial cell, right? So this cluster is positive for mesothelial cell. However, in our practice as a tertiary hospital, it was always very complicated. So we have seen a couple months ago a patient with thymic carcinoma, but developed a mesothelioma after that. So we will do a BAP1 to confirm there's no BAP1 loss for this case, because we've seen so many strange cases that you cannot imagine. So the next specimen is a CSF specimen. The patient had a past history of lung adenocarcinoma. So they were very scant cells in the CSF specimen, but the cell definitely show enlarged nucleus and eccentric nucleoli. Here is a cluster. And here is also more pleomorphic and eccentric nucleus. So this is positive for metastatic adenocarcinoma. The next specimen is also not very common to see. Probably we will see 1 or 2 every year. So this is a pericardial effusion, not pleural effusion, pericardial effusion. The patient had a past history of esophagus squamous cell carcinoma. So squamous cell carcinoma rarely will go to body cavity and to show body fluid accumulation. But in this case, it is definitely positive for squamous cell carcinoma. We only have keratinized cell here, but because it's a pericardial effusion, there's no way there would be benign squamous cell like a lesion inside this area, and the patient show definite history of esophageal squamous cell carcinoma. So this is positive for squamous cell carcinoma. It almost looks like a rupture of the tumor inside the pericardial cavity. So usually for the metastatic squamous cell carcinoma in the body fluid, they will show very tight cluster of cells, and you will see flattened cells wrapping around the periphery of the cell cluster. That's a typical case, and for those cases, usually there's no very prominent keratinization. But in this case, this is unusual, but we see mostly single cell with well-differentiated, this keratinized cells. This is not very common that we will see something like this. So this is from the patient's pericardial effusion. He also received soft tissue mass aspiration with a lot of like a fluid. So this is from the side, from the soft tissue of the side. And they rule out soft tissue metastasis. So here we also see similar morphology with keratinized squamous cell carcinoma. So this is also positive for metastatic SCC. In this specimen, we didn't see definite, like very high NC ratio immature cells. We only see scattered these type of intermediate cells, but because of the clinical scenario and because of the morphology, it's definitely just necrotic keratin debris, and we will still call these squamous cell carcinoma. So this is from pleura effusion. The patient had lung cancer. So this is recurrence lung adenocarcinoma. So this one is easy. So next, let's move to some aspiration cytology. The first one is from lung. So the patient had a nodule in the lung. So she received CT-guided biopsy and aspiration. In this specimen, you can see the cell is very hyperchromatic. But here, there was still a little bit of like a glandular feature. So here you see more cytoplasm and the glandular architecture. And the other thing that I want to show is that primary lung adenocarcinoma, it is not uncommon that you will find pseudo-inclusion in the cell because normal pneumocyte, activating pneumocyte will show pseudo-inclusion. So it is not uncommon to see pseudo-inclusion in the lung adenocarcinoma. So even though in this specimen there is no prominent nucleoli, there seems to be more hyperchromatic than usual. So it's more hyperchromatic than vesicular chromatin pattern. But because of the cellular arrangement, it still has glandular arrangement. And because that we see a pseudo-inclusion, there were actually a couple of them. So we call these adenocarcinoma. We can also call this non-small cell in favor of adeno. Yeah, but because the patient already had a TTF1 positive pleura effusion, so we call this adenocarcinoma. So the next specimen is from parotid gland aspiration. The patient is a 64-year-old male with past history for smoking for 30 years. So before we see the slide, we were already thinking about, okay, these could be a Watson tumor, right? The liquid-based cytology is very paucicellular. Basically, there's very, very scant cellular component here. And we only see some granular stuff and some unknown cells over here, and that's it. For the direct smear, so we see aggregates of histiocyte. These are all histiocyte. These are not epithelial cells. So sometimes histiocyte can aggregate together in a cluster and make you think, okay, could it be epithelial cells? But you have to pay attention to the character of the cytoplasm. So you see granularity and the small bubbles inside the cytoplasm, foamy type. So these are all histiocyte. These are not epithelial cell. So we didn't see epithelial cell, we only see histiocyte. So supposedly it's a cystic aspiration, it's a cystic specimen. And here we also see one cluster of very hyperchromatic but small size cells. These are lymphocytes, right? You can tell from these like a slightly like clumped chromatin pattern and high NC ratio. These are all lymphocytes. So we see lymphocytic stroma here. So we have lymphocytic stroma, we have cystic background, and that's it. So originally the Cytotec signed out it as the Milan category 1. I think this is very good diagnosis. But because we have residual cytolytic specimen and our tech who prepare specimen show there might be tissue, so we still want to order a cell block for these specimens. So this is the cell block preparation. There are more cells over here. So basically, we see similar finding. We see lymphocytic stroma, we see cystic background, and we see more cystic background, more lymphocytic stroma. But we still didn't see any oncocytic cells. So we have to call this specimen non-diagnostic. But because of, I think it's kind of tricky because basically either way it's negative for malignancy, right? It can be a benign tumor or it can be just cyst. It's a little bit strange to call it non-diagnostic. But I think the way that we call it non-diagnostic is that we want to diagnose it as Watson tumor, but this is non-diagnostic. So we still make a note. I make a note in the report that it is compatible with cyst content and the lymphoid stroma of Watson tumor. But because we don't have the epithelial cell, so they need to have clinical correlation. Yeah, because I don't think it's good for the patient to keep repeating biopsy for apparently benign lesion, right? So the next specimen is from a salivary gland, from the thyroid gland. This is a very pulsy cellular aspiration. For the short path specimen, there is basically very scant cells, though there were a little bit more cells in this direct smear. So on low power, basically in the background, we only see some blood. We didn't see apparent colloid. And we see some cluster of follicular cell. These follicular cells show overlapping nucleus, and the nucleus is slightly enlarged. Okay, and it also show these microfollicular pattern. So because scan colloid, basically no colloid, and there's microfollicle, and the nuclear feature is also a little bit enlarged. And we see in one or two clusters, and there are areas of suspicious for pseudo inclusion. I checked the sonography of the lesion. It is almost 4 centimeters, like well circumscribed nodule, and with capsule like a hypervascularity. So it looks like a follicular tumor. So this could be a NIFP or this could be a follicular adenoma. And we call this AUS with cytology and architecture atypia because there were definitely some areas show a little bit of nuclear atypia. But I would say this type of nuclear atypia is more aligned with the RAS type instead of the BRAF type. So this is AUS. And from the sonography finding, the clinician already know that it is a follicular tumor. The next specimen is a lung specimen. So everybody now is very familiar with this because Hui Zhi has told us 2 days ago. So what is this? So this is fungal hyphae, right? This is fungus. And did you see septum? So there seems to be septum, right? So for the branching, it's like right angle. Okay, so this is aspergillus. So this is Aspergillus infection. Okay, so we have a lot of, ooh. Okay, so this is Aspergillus. So let's save these for teaching slide. So let's move to pap smear. This is a 92-year-old female. Theoretically, we don't need to screen patient for cervical neoplasia after age of 65. This is a 92-year-old female. She has been proven to have HASIO last year and with comb and everything. So you can develop HASIO at the age of 92. This might probably be the oldest HASIO patient that I ever seen. So we never say never, okay? So this is a follow-up pap smear for the patient who has received complete surgery, completion treatment, including cone with a free margin. And usually in this scenario, the patient will have follow-up pap smear every 3 months for 1 year. So this is a follow-up specimen from a very old lady. So in this scenario, even though she is 92, we shouldn't interpret this as an atrophy feature, okay? This is too much for atrophy, okay? So this is not atrophy. So I think we'd better call this Ascus high. So this is a good example for Ascus high. So the cell is not well preserved, but it is markedly enlarged with very strange shape, right? And we cannot see coarse chromatin because it's not well preserved, but this qualify for Ascus high. So this is a very good cells for Ascus high, okay? So we should not see these like an aging change. These are not aging change. So here as well, this looks very suspicious for high CO. Okay. So we call this Ascus high. So the next specimen, we call this the prior specimen from this patient CIN2. Like 6 months or 4 months before. But she received biopsy which show negative. And so she has go back to pap smear like a follow-up, but we still see something like this. So I'm still calling this CIN2, okay? So sometimes there would be discrepancy between pap smear and colposcopy biopsy, but sometimes it's because the lesion is too deep or because the lesion is very tiny and it's not easy to be inspected by the clinician. So sometimes you need to have a couple rounds and then to have a definite biopsy. So for this specimen, I'm still calling this CIN2. So the next specimen is also in a similar situation. This is a 41-year-old female, relatively young. She had the past history of high CO, but not in the cervix, but in the vulva. So she had the vulva high CO, and with wide excision and with a free margin. So this is, again, a follow-up specimen for potentially precursor lesion. So vulvar lesion usually show more like a differentiation comparing to the cervical lesion. So sometimes the high CO lesion can be really keratinized. So sometimes it's not very easy to make differentiation of a low-grade lesion or the high-grade lesion. And in this case, we see quite some cells actually with features of low CO, but the cell is not that big. So I think we cannot call these benign. Okay, this is not negative. So they are like a borderline. I'm actually debating: should we call these loci or should we call these ascus only? Yeah, but because the patient has prior biopsy, which is negative again, so for these cases, I decide to call the just ascus. But if somebody want to call it loci, I think it's also okay. Yeah, but sometimes you call it loci, or there's no like a biopsy proven lesion, that would be quite problematic for the clinician or for the patient. They will worry too much. So I still decide to call these ascus. Okay, so this is a ascus case. Okay, that's for today. So let me show you how to